Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we will be hearing a discussion from two expert faculty about practical strategies to incorporate depression screening, diagnosis, and treatment into the care of people living with HIV. For this episode, I'm joined by Dr. Brad Gaynes from the University of North Carolina and Dr. Glenn Treisman from Johns Hopkins. For more information about this program and to follow along with the accompanying slide set, please visit the links in the show notes for this episode. And to get access to all of our new infectious disease podcast episodes, subscribe to the CCO podcast channels on Apple Podcasts, Google Podcasts, or Spotify. Now, let's get started and hear from Dr. Treisman.
Hello, everybody. My name is Glenn Treisman, and welcome to a clinical care options program called Remind. This is a program about making mental health care an integral part of HIV care. As those of you who know me know, I've spent most of my career, as Dr. Gaynes, who will be joining us today, has, in trying to make sure that patients with HIV care get optimal care. And mental health care is very important in this population of patients. Today, I'm going to be joined by Dr. Brad Gaynes. Today, we're going to be talking a little bit about a condition called depression and the way depression is important in HIV care. Welcome, Dr. Gaynes.
Thanks, Glenn. Great to be here and glad to be able to participate.
Well, I can't tell you how much I appreciate you joining me. I've prepared a case for us to discuss initially. This is a patient from our clinic. He's a 42-year-old man with previously well-controlled HIV who was referred to us because his viral load kept going over 1,000 copies. And particularly his last two visits, he's had a bump in his viral load. His primary care doctor in our clinic was very concerned about this, and he admitted when he saw us to missing doses of his medicine, mostly because he said he often just doesn't feel like taking his medicine in the morning and misses it. He also admitted to poor sleep, early morning awakening with difficulty going back to sleep and worrying about his problems, and watching TV whenever he wasn't working. He's a very active person who works full time, but when he would come home, he usually had many things he did at the house. He said, I just don't feel like doing anything, so I watch TV all the time. He's lost interest in most of the activities he's usually involved in. He denies being depressed, but seems flat and apathetic to me on exam, and he seemed less engaged in conversation with his primary care doctor. He's been having a number of romantic problems with his partner and romantic disagreements, and is considering breaking up with his partner of many years. Very unusual for him. They've had a very stable relationship for a long time. So the first thing is, what do we think about in a patient like this? And how do we think about it? So I thought we'd start there. Do you think this guy has depression?
Well, there's certainly a lot of things that make me think he may. A couple things about depression. One is when we talk about depression as a disorder, it's different from just some symptoms that any of us might have at different times of the day or different times of our life when we're reacting to one thing or another. With depression, it ends up being severe enough and there long enough that it really starts affecting things. People are really functioning a bit differently than they normally would in other parts of their life. So it starts affecting these important parts of their life, like romantic relationships, or sometimes not being able to do what you normally do at work or in other interpersonal relationships. So it gets to a severe point that it really affects your everyday life. And it's something that oftentimes other people can see it, but not necessarily always the individual themselves. The point you make about his having lost interest in most activities, that's a really important one to follow up on. One of the things that we've noticed is that it may be hard for someone to say, yeah, I feel depressed, but they're able to say they just don't get the same pleasure out of doing what normally brings them pleasure. And that really stands out when you're describing this fellow here.
Epidemiologically, we've studied depression a great deal, and so has your group. We know some of the correlates of patients with depression compared to those without depression. In general medicine, we know that patients with depression have a poor prognosis for most diseases. The best demonstrated being heart attacks. People with depression post-heart attack are much more likely to have another heart attack and die. People with stroke much more likely to have another stroke and die if they have depression. What do we know about depression in HIV patients?
We know a couple things. You've highlighted a lot in your work. It has effects that are both biological and behavioral in ways that can make the HIV outcome worse. So, for example, in terms of the biological things, we know that folks who are severely depressed have immune systems that don't work as well. And that can actually increase their chances of having a more severe progression of disease. And behaviorally, because they're not really functioning like they normally do, it can decrease their ability to take medicines, which are going to help keep their HIV under control, or make follow-up appointments, or engage in other healthcare pieces that are really important to the care of HIV. So it really gets it in both a direct biologic way, but also in an indirect way through not participating as much in a lot of the normal healthcare maintenance pieces.
Right. And as a consequence of that, various epidemiological studies have shown that patients who are depressed compared to those are less likely to come get diagnosed, more likely to die, less likely to take their medicine, more likely to have comorbidities, less likely to get to undetectable levels, and they're less adherent to medications in general, not just HIV medicines. So,
and part of that less likely to get diagnosed, like you're suggesting, is even if they get diagnosed, they'll get diagnosed later in their course, which also has an effect on what that overall trajectory is.
Yeah, that's a very good point. So in this guy's case, he's not taking his medicine, and that's what brought him to our attention. So when we talk about depression, we talk about it in relation to HIV. Like you said, we think that depression makes HIV worse. We think that HIV is pro-inflammatory and causes depression. And I think that little cycle of depression worsening HIV and HIV worsening depression is important in our population of patients. And I think that most patients think of depression as a psychological problem, don't really think about the physiological elements of it at all. But our colleagues should certainly know that if you don't think about the inflammatory elements and the behavioral elements, you're going to miss a lot of what this disease does. So what do we know about the frequency of depression in our population of patients compared to other patients?
Well, we know that in HIV, the likelihood of being depressed is higher than you would expect in the normal population. So it increases that risk a couple times relative to what you would usually see in someone coming into your clinic. So we know it increases that risk. It can also increase the risk of other psychiatric illnesses. You want to look at things like anxiety disorders of some particular kind. You might look at drug use. You might look at kinds of post-traumatic stress disorder. But here, I think it makes a lot of sense, here we're going to be focusing on major depression, which is probably the most common one that folks are going to see. And if you have HIV, you want to keep a good sensitivity out for these different psychiatric and substance use diagnoses. But depression is one that's really common and one that we know a lot about how to help folks with. So it really is a key one. It's associated with a number of other psychiatric illnesses folks might have. But if someone can identify and then begin effective treatment for the depressive illness, you're actually going to help those other ones probably get better too.
Right. So our early study, we used a method of identifying depression that will identify a population rate of about 4%. And in our clinic, we had about a 5-fold increase over background. And other people have used other methods of identifying depression, so they get different numbers. But in most of these studies, it's 3 to 6-fold increase in depression over the general population, along with the other things. There is a relationship between depression and anxiety, depression and panic attacks, and depression and drug dependence. And so those things are worsened by untreated depression as well. So let's talk a little bit about depression in people living with HIV. Do we pick it up? Are we missing it? Are people diagnosing it?
Over the last 5, 10, 15 years, people have gotten better at identifying depression. Primary care docs and HIV docs and OBGYN docs, meaning clinicians who really are primary care providers for folks. They've done a really nice job at better identifying and looking for when a depression is there. So the identification piece is getting a little bit better. The next step then becomes making sure someone gets an effective treatment and then actually gets a effective dose of whatever that treatment is. And that's where we can find that folks can probably do a little bit better in starting at a good dose, but then depending on someone's response, to know that it's time to increase a dose of an antidepressant and to be able to follow that response so that we can really treat them to remission. We know that depression is associated with a greater likelihood of not adhering to medicines as prescribed, ART medicines, as well as other kinds of medicines. And we know that if we can treat that depression better, folks will adhere better to the various medicines that they're taking, ART medications, antidepressants, and other maintenance health medicines. So it's important to identify, and people are doing, I think, a better job at that. But then that next step, beginning an effective treatment and making sure someone has an adequate dose to get a good treatment trial, I think that's really the next place that we want to really try to help folks improve.
Okay, so I want to talk a bit now about what we mean when we say depression, because like you said earlier, depression is both a symptom and a condition, depending on how you're defining it. So the psychiatrist used to use the term involutional melancholia, and then later major depression. And what do we mean when we say depression? Well, patients mean my mood is low. So plenty of people with major depression disease don't identify themselves as having a low mood. They may be irritable, they may be anxious, they may be flat. But when we use the term depression, we're talking about a condition that is, for most people, a condition that comes and goes through life, that occurs episodically, during which they have less reward from activities. So I use the term anhedonia for that. They often have early morning awakening. They usually have some family history. They've had similar episodes. Frequently, they've had a disrupted life because during the episodes of depression, they get off track and then get back on. And when they're depressed, they're usually unresponsive to positive events in their life. There's another condition that I use the term demoralization for. People use the term grief. This DSM likes the word adjustment disorder. But in these people, they're demoralized. They have the understandable psychological response to loss that everybody has. Usually people with grief are distractible from their loss. If they have insomnia, it's usually difficulty falling asleep. Once they're asleep, they usually stay asleep okay. They don't have a family history. It's a unique episode related to a particular event. If you look at their course of their life, until this happened, they were doing usually the same over the course of life. It may not be good, but it's stable. And when people are demoralized in grief, even at the funeral of somebody's loved one, if you distract them, they will often be their old self. That is, they can still laugh at a joke and then remember that they're at a funeral and start crying again. But they're distractible from their loss. They're still quite functional. And if they win the lottery, they still get a lift, even though they're demoralized by what's going on. In fact, often if people have had adverse life circumstances and they're demoralized, when they get a financial bonus, financial positive event, it will relieve the demoralization. Depressed people are relatively unaffected by good news. So that's, when I say depression, that's what I mean, the disease kind rather than the psychological kind. Do you have a similar rubric? Do you have a way of thinking about, I know you've done a lot of work to identify ways of screening for depression and ways to track the response to treatment. But do you have a thing in your head when you say someone has depression that's like that? What's your rubric?
You've identified a couple critical pieces about why it's so important to distinguish between a major depressive disorder and demoralization or adjustment disorder or some other less severe response. You highlighted a couple critical things. You noted episodic. And not only is it episodic, so what happens, it has its own time limit. Untreated, that time is actually a lot longer, but it's episodic in the sense of it's different from someone's normal baseline. So one of the ways that we'll look at trying to distinguish between a major depression and maybe just some other demoralized or depressive symptoms is that it is a clear difference from what their
baseline
is. Another thing we want to look at is making sure that those symptoms that cluster of symptoms is really there long enough. So we'll want to know that they're there for at least 2 weeks, most often longer, but that it's really this cluster of symptoms is happening for a couple weeks or more. And like you said, it disrupts the life course, that their ability to participate in life like they usually do, it's not there anymore. They're in bed all the time. They can't go to work. They don't really have any more social interactions. They're not wanting to enjoy, as you mentioned in the case before, time like they usually would with their romantic partner. So those are really important things to identify to help distinguish. And just to point out, we know that particular medications can help with a major depressive disorder. For demoralization or an adjustment disorder, we look at a different intervention. So it's important to make this distinction.
I'm going to just say it right out. I don't think demoralization responds to antidepressant medicines. There are people out there in the universe who will argue with me because they think these things are on a spectrum rather than discrete entities. But my opinion is that if you can successfully distinguish between demoralization and depression, you need to know whether to use an antidepressant. Even mild major depression will respond to antidepressants. Even severe grief won't.
That's exactly right. Again, underscores a critical reason why this is something we want to be able to identify and to help really figure out what the next best step is.
Now, the stress-related demoralization in some people will trigger a depression because you have both. And I think that's an important thing to stress, that people can be demoralized and have a major depression going on at the same time. Often when they're depressed, they're less upset about their loss because they don't have any energy to have much emotion. But they nonetheless can have both things. And it's important to know that and look for them.
It reminded me that when we assess for depression, just remembering this is not just like a one-time thing you would check for. Whenever we assess someone's depressive state, we don't know whether they may be recovering from a depression or developing a depression, or maybe just have a chronic low level of depression they usually have. So what you mentioned, it was a good reminder for me, is that screening, assessing for depression, it's not a one-time thing. It's something we're wondering about. And maybe that when we see someone at a first time point, that's not what they have. We see them a couple weeks later, things have progressed or continued or gotten more severe. Again, we want to remember that that's something important to look for.
That's a very good point. I do think that people have a tendency to screen for depression and then they're done.
Right.
And you really have to screen for depression at every visit pretty much. So I want to talk a little bit about what we do to figure out if someone's depressed. Take us through your view of how you think about evaluating a patient to see if they're depressed. Not talking now about screening. Let's suppose someone's come to the clinic and you screen in your clinic and their screen was positive and now they're sitting in your office. What things do you look for particularly?
So that's a key point. You're identifying that the screening piece has been done. And just to remind that a screen positive does not necessarily mean someone has that illness. It's a positive screen, but we know that sometimes they're false positives, sometimes they're false negatives. When someone comes in and screens positive, I'm going to want to follow up. The first thing is to really confirm that the person does have symptoms that, to me, make sense, meet criterion for a major depressive episode. You can use the screening instrument just to go back over it and confirm that the patient answered it correctly. It does look like it was 2 weeks or more. They do have a collection of those things. They have affected the individual's functioning in some way. So the first thing I do is confirm that, yes, I think that's the diagnosis. The next step then is to remind that a major depressive episode can be part of a major depressive disorder, but you also might see it in other psychiatric presentations. It might be part of a bipolar disorder, or what sometimes people call manic depression. It might be part of a severe psychotic illness. Someone who is severely psychotic could be related to the HIV, could be related to substance use, could be something different, but they also can look depressed when they come. I'd want to screen and make sure there weren't any obvious psychotic symptoms or delusional symptoms that might make me start to wonder about other diagnoses. People have different acronyms to use. The key things for me are, I always want to think that the main two first questions, is there depressed mood or that anhedonia, loss of pleasure piece? If they say no to both those, I'm less concerned about a depression. But in addition to that, if they do say yes, they start looking at other things: sleep, energy level, attention concentration, thoughts of worthlessness or guilt, and thoughts of wishing they weren't around anymore. How about you? How do you approach it?
Well, I'm pretty much the same way. I'm very big on the anhedonia part because if you look at a population of people, the average person will say, I'm depressed. There are a lot of people who don't pay very much attention to their mood. There are other people whose moods are quite variable, and they can go from being suicidal to being euphoric to being suicidal in a 15-minute interview.
Mm-hmm.
So people with labile moods who are symptom amplifiers, you might miss them. People with flat moods who are not very emotionally rich, you might miss them. I look for the anhedonia thing. The one thing that is united patients when I've seen them is that they lose that reward, that enjoyment, the pleasure, the drive for, the hunger for, the craving for, things that are usually rewarding for them. You have to know what's rewarding for them. So you have to know the case well enough. Because if you said to me, are you still enjoying bowling? I'd say no, because I never liked bowling. But if you said, how do you feel about sushi tonight? And I said, then you'd probably get the nets. So it's very dependent on the person and knowing the case a little bit to make that part of the diagnosis.
Yeah.
And then the usual things, looking at their past history, their family history, their social history. Do they have a disrupted life course? I talked about that a little bit. Did they drop out of school unexpectedly? On a review of systems, do they have a bunch of physiological things related to depression? And then we do the mental status examination that I'll let you talk about for just a moment, but essentially to look for mood, vital sense, and self-attitude. I think that that's an overview of what we look for when we evaluate patients. I don't think screening is diagnostic, and I think that people do have to walk patients through this effortful exam because I think that the drugs are not totally benign. And I think that just treating people because they're screen positive is not very responsible for physicians. I think you have to think about your case. My guy that I told you about at the beginning, he had major depression. He had anhedonia, an early morning awakening. He had a history. When we pushed him through, he's positive pretty much all up and down the stream, except he said, I'm not depressed. So he was actually diagnostically very clearly depressed. Tell me a little about these rating scales that we use to screen people.
So there are a number of rating scales available. We've done a variety of studies comparing how well they work, and really all of them work with about the same accuracy. So they're all pretty good. What you want to do is choose one that is best set up for you and your patient population and your clinic setting. There are a number of possible ones. The ones that we probably like the most are self-report ones. They tend to work as well as the more clinically trained one. They're set at 5th or 6th grade reading level, so most folks are able to read them pretty well. You can also read them to the patient, get their answer, and that actually works pretty well as a way to assess also. But the self-report ones work pretty well. We tend to like the PHQ-9 for a couple reasons. One, it's PHQ-9 9 items. Those are specifically denied items that meet the DSM-5 criterion for depression. So it really guides you well along what those specific symptoms are. The cutoffs are easy to remember. So 10 or more would be considered a positive screen once you confirm that's at least a mild to moderate level of depression. The studies show that if it's a score of a severity level with a PHQ-9, for example, of 10 or more, that has evidence to support better outcomes from an antidepressant compared to placebo. 15 is a moderate level of severity, 20 and above, more severe. Those all are easy to remember. You can also use the PHQ-9 to modify response to the goal for treatment is less than 5. That would be considered recovery or remission. So for us, we like self-report, ones that are easy to use and also that can be good for monitoring response. And PHQ-9 is a public domain, excellent self-report.
Public domain means free.
Public domain means free, and not all of them are free.
Yes, exactly.
So the PHQ-9 for us is a pretty useful one. The CESD is used in a lot of studies. I've found, I'm not sure what your experience is, but I've found that from a clinical perspective, it doesn't directly apply to a clinical idea of a depressive illness quite like some of the other tools. So we don't use that much clinically, although it can be helpful in community studies of depressive illness in populations. Most clinical trial work, they'll use tools like the Hamilton Depression Rating Scale or the Montgomery-Åsberg Depression Rating Scale. Those are good scales and they're quite sensitive, but you have to be trained to do those. And those are always clinician administered. They take more time, both through the training as well as through the administration, the scoring. So useful, I think, from a research end, less so from a clinical usefulness end.
Yeah, I agree with you. These were initially developed to track response to treatment, not to screen. They have become screens, but I want to point out that they aren't diagnostic. They were tools to rate the severity of the illness, and therefore their utility as screeners is not nearly as good as your acumen at evaluating a patient. And there are way too many places that say, if they have PHQ-9 above 10, give them Prozac. And I think that that's not how we want to do clinical care.
Correct. You want to follow that up with a confirmation. Clinically, you want to be convinced that, yes, what this presentation looks like is a depressive disorder.
I'm going to point out that you're going to talk to us about measurement-based care and thinking about how we're tracking patients. And we're going to talk about that in a minute. But before we get to that, I want to talk just a minute about treatment. And I think that the most important thing about treatment is that you have to know what you're treating. After that, most people don't get adequate doses. Most patients stop treatment too soon. Most patients are treated to improvement, but not all the way to remission. And there's some pretty good evidence that if you don't treat people all the way to remission, they are much more likely to relapse than if you treat them all the way to remission. And most patients don't get adequate efforts to optimize their therapy. I saw a patient yesterday who's been on 4 SSRIs, who's never been well, who's still quite ill for more than 20 years, and never had any augmentation, never had trials of anything other than an SSRI antidepressant. So I think that you have to optimize your therapy. And the last thing is the internet is not an adequate substitute for medical school. Please educate patients about what we're doing and why we're doing it. Do you have anything to add to that, those caveats?
I think those principles are really important to getting a good treatment of the depression. And we'll talk about measurement-based care shortly, but measurement-based care is really focused on trying to address each one of those problems that you highlight here. And again, the main goal is to give someone a good, strong, adequate trial.
I agree with you. I think that the measurement-based care and trying to optimize I have seen so many patients that measurement-based care for me is just looking at what t-shirt somebody is wearing and knowing that that's the right t-shirt for them to wear versus not. But in the hands of the average clinician who's adding depression in to treating a whole patient, I think you have to have something that allows you to know where you're going.
Yep.
So I have a slide summarizing the major classes of antidepressant drugs that we use. For the audience today, I want to just point out that SSRIs and SNRIs are easy to use. They're relatively safe in overdose compared to other drugs. You don't need to get levels. They have good anti-anxiety activity. The SNRIs are also good for pain and migraine. All the serotonin drugs are pretty good for OCD and are fairly effective for that condition. The drugs are listed on my slide. There's atypical drugs that have particular uses in certain patients. I won't talk about them in excess today, but bupropion tends to be an activating drug. Trazodone is great for sleep. Mirtazapine, great for sleep, good for pain, unusually well tolerated, but makes people gain weight if you're not very careful, and often will not be able to be used because of the weight gain issues with mirtazapine. But it's a great drug. And then I have tricyclics on here, which are expert drugs. They are dangerous in overdose. You can die from an overdose of the tricyclic, a 1-month supply. But experts are going to use them a lot because they have particular uses in subsets of patients who are very difficult to get well on the other drugs. I haven't gotten everything on here, monoamine inhibitors, nafazidone, other things that we use. But this covers the waterfront of medicines. What things in your work with measurement-based do you tell people about thinking about drug choice?
So a couple things, and again, just to and highlight some critical things that you had mentioned here. You'd mentioned the differences in the side effects and risks and adverse effects. Those are really the only things that differentiate these. From a benefit perspective, SSRIs work well, SNRIs work well, the atypicals do, and the tricyclics do. But where they differ is in the side effects and in some of the risk of taking. And as you said, the SSRIs and the SNRIs are all quite safe. If someone uses too much, there aren't concerning withdrawals. For many of these, venlafaxine may have a little bit of a withdrawal issue if people are on high doses and stop it cold turkey, but it's not a risky one. It's just an uncomfortable one. So those are all safe. Wanted to highlight a couple things with the bupropion and the mirtazapine piece, which is depending on, in a lot of our HIV patients, if most of the concern, what's the most distressing thing is how low in energy and how just bedridden folks are. Bupropion, that more activating one, can be pretty helpful. Other times, if the most distressing thing is either the poor sleep or they don't have any appetite and they're losing too much weight, again, the mirtazapine can be a useful one if that is the most distressing presenting symptom that the person comes to you with. You'd wondered about how this applies to the measurement-based care part. Any antidepressant that you start, it's not like a sleeping medicine or one of those immediate anti-anxiety medicines where you get the benefit within 15 minutes or something. In terms of the benefit you'll get from any of these medicines, it's going to be on the order of 2, 3, 4 weeks. So it becomes real important to make sure you give someone enough time to demonstrate a response, that you get to the best dose that's going to give them the best likelihood of responding, and that you're also assessing for their ability to tolerate. Because if they can't tolerate it at all, you're going to know it's time to switch to something else. And those kinds of considerations are things that measurement-based care has built into it.
All right. I'm not going to go through them in detail, but there are a number of things people add to augment antidepressants. You get somebody substantially better, but not all the way better. These augmentation agents, some of which are FDA approved, some of which are not, but all of them have some level of experience or data to support their use, are important for people to know about. The way I tell audiences is learn to use one or two of the antidepressants.
Yep.
And once you're there, ask experts to tell you how to try augmentations, and try augmentations till you get pretty good at them, because they make a big difference in patient outcomes.
I think that really is exactly true. Your point about learn one or two agents pretty well. In STAR-D, which was the largest prospective clinical trial of depression ever conducted in the States, we compared folks who were at a primary care clinic, similar to what an HIV clinic would be, and compared them to folks who were depressed in a psychiatric clinic. And we provided adequate clinical treatment trials of antidepressants. And the primary care docs and the HIV-like docs did just as good a job for those, really the first 2 times of trying to treat the depression, as did the psychiatrists. After that second time, when they weren't able to successfully treat the depression, at that point, the treatment part got a lot more complicated. And probably at that point, it made sense to refer on to a psychiatrist, but the non-psychiatric physicians were pretty good about finding 1 or 2 antidepressants that they knew pretty well and treating people quite effectively with it. It was really after that second failure to recover that it made some sense to consider a referral there.
Yeah, most people would say 2/3 of people will get better in any drug you pick, and 1/3 of people are hard to treat. Those are very coarse numbers, but that's about what it is.
Yeah.
What about psychotherapy for depression? What are you going to tell me about that?
Finding the proper role for psychotherapy is important. Now, psychotherapy can be used actually for a couple things in both HIV trials of depression as well as other HIV treatments. People have used cognitive behavioral therapy both to help with the depression, but also really to help with a lot of times adherence to medication. So it's always good to wonder about the role of how cognitive therapy might help someone manage stress so that not only might their depression get better, but also, they would find some strategies to better adhere to their ARTs. Something important to consider. It's harder to do, and it may not work as well for most of the moderate and severe symptoms that we'll see in our population here. So usually what we would do here is as a primary treatment, if someone meets that major depressive disorder diagnosis, we'd probably begin with an antidepressant. And if that did not completely work, then we'd wonder at some point, do we want to augment with a second medication, or might we want to augment with an evidence-based cognitive behavioral therapy? So that's kind of where at least I see the role of psychotherapy being. It can end up being something important to consider, especially in those who aren't responding to what our normal approaches might be. But what do you think?
Well, this is a personal opinion. I don't think psychotherapy prevents episodes of major depression. I think depression is a disease state of your brain and has much more to do with biology than your experiences in life, although I think sometimes stress will trigger it in a vulnerable person. But I do think psychotherapy helps people cope with having depression, helps them function better, and will get them through depressive episodes much more easily than medication alone. I don't think SSRIs in a vending machine are nearly as effective as antidepressants given by a skilled clinician who can also help people be remoralized and help them cope using behavioral therapy or supportive psychotherapy. So I'm big on including psychotherapy in the treatment of patients, and almost every patient I treat for depression gets psychotherapy. Having said that, I don't think it's curative of depression. And I think that patients have an idea that somehow it's psychotherapy or antidepressants, not psychotherapy and antidepressants, which is what I encourage people to do. So I want to talk for a minute about setting up a virtual system for providing better care for patients. What I'm talking about is this. We have in your place and in my place an integrated model where psychiatry, psychology, social work, treatment are integrated into the HIV clinic. We're there. They don't have to come to us. And in fact, when we tried to send people early on, back in the late 80s, we tried to send people to the Department of Psychiatry from the HIV clinic, and nobody went.
Yeah.
Well, we came up with the idea of treat them where they lie, and we would go to the clinic. We had very, very good outcomes. But a lot of people don't have mental health services in their clinic, and yet they have a lot of major depression to contend with. So I like to think about this idea of a virtual collaborative network. Have you done some of that?
Yeah, we've done that here, and we provide that actually to a variety of non-mental health clinics. So HIV clinics, primary care clinics, OBGYN clinics, and even other places within our system that might want some degree of psychiatric input. So yeah, I think the ability to work through a virtual network really extends the reach of how we're able to help and work with folks. And it helps make sure that the treatments that are begun in, for example, an HIV clinic are more likely to become adequate trials. We can provide feedback about dosing and about confirming diagnoses or other comorbid illnesses that might be there, how well someone's responding, other medications to consider. So as a first step, that virtual collaboration is pretty important. Now, I might point out that also, at least in our clinics here, we'll have some mental health professional also available in the clinic, usually a social worker who can provide a first step like collaboration to the team with knowing that there is available a psychiatrist should some of the questions get a little bit more complicated. But what do you guys do?
Same. I think you said it perfectly. I think that this is my segue into talking about measurement-based care, because as part of a virtual network, you want the clinicians to know, to have a way of knowing how they're doing with the patients. And you can't fall back on the experience that someone who does this all day, every day has. So you have to know when to get help. And when you get help is when your patient isn't doing well. And how do you measure that? So this is my segue into asking you to talk a little bit about the work you've done in measurement-based care. HIV clinicians who send someone to a psychiatrist, often the psychiatrist sends them back to you and says, I'm too busy, or I can't do it, or this is too complicated for me, or the medical issues are too much. You're going to end up doing it as an HIV provider. And how do you do that? So I'd like you to talk a little bit about that, if you would.
Sure. Part of its descriptor is this notion of measurement-based care. So I think the key things really to keep in mind is that We want to measure things with validated tools, and we want to measure them in an ongoing way. So what are the things we measure? Well, we can use tools to help us both screen and also confirm a diagnosis of major depressive disorder, as well as its severity. So that's something that's measured. It's really important that we measure medication side effects, because the greatest risk of someone who started a medication is that they don't take it long enough and they're not taking it and they don't tell you, but it's because of it could be the sexual side effects, it could be the upset stomach, it could be something that actually might be relatively easily addressed. But if it's not monitored, that becomes a reason for someone to stop the medication. They'll go ahead and do so. So we measure symptoms, we measure side effects, adverse effects, how well they're tolerating it. We measure their adherence. How consistent are they with taking the antidepressant that we're prescribing? And we also want to get a sense of how well they're functioning. And that could be really a self-report, or they've identified the important activities they want to do. And that's something that we'll also follow up. And we'll measure those at different times. So we'll confirm those things right as we start the antidepressant treatment. So we measure it, and we might consider that a week 0. Again, it takes about 3 months before you can give a full trial of an antidepressant. So we'll measure at that 12-week period. But it's really important to make sure the person is taking the medication, that they're tolerating it, that there's some indication that they're beginning to respond to it at about 6 weeks. So what we'll do is we'll measure it again at that baseline period. We'll start the medication. Maybe around 4 weeks, 6 weeks or so, we'll make sure they're taking it like it's prescribed. And we'll, again, measure that adherence rate. We'll measure their depressive severity, and we'll measure what their side effects are. And depending on those things, we'll decide what to do next. If someone's tolerating it and they have a bit of a response, but they haven't hit our treatment goal, recommendation would be to increase the medication. If they actually can't tolerate it, so they're not able to really get a good medication trial on that medicine, we'd look at switching to something else. If they aren't taking the medication and it's not because of a side effect, but some other reason, maybe they're concerned about interaction with another medicine, or maybe it's a matter of being worried that they might become addicted to an antidepressant medication, which is not a risk. We can maybe address that with medications. What we'll do is really measure that response and that toleration so that we can push as much as we can to a solid, at least moderate to maximal dose of that antidepressant, so we can get a good sense of whether they're responding to the medication. What we usually do, for us anyway, we at 4 weeks will collect this information over the phone, and again, assess their severity, their toleration, how well they're adhering to the medication. At 8 weeks, ideally, we'd see them in person, and we can get a sense of whether they might need a higher dose or maybe some help with the side effects. But we're interested in what happens at 12 weeks. At 12 weeks, we measure these same things, the severity of their symptoms, whatever side effects they're having, how well they're adhering to the medication. And then we'll decide what to do next. You talked about the treatment resistant part. So the question then becomes, what do we do next? Do we switch to a different medicine, or maybe add a second medication to try to help boost the response? Those would be the things that we would look at with measurement-based care. What's your approach to this thing?
As a psychiatrist, when I see patients, I don't use much measurement-based care, because my resolution of psychiatric symptoms is much better than the instrument. That is, posture and color choice and facial expression and physical movement, psychomotor agitation and retardation, vocal range, get better granular information than measurement-based care does. But when I'm setting it up in somebody's clinic, which I do a lot,
right,
and talking to them about it, then I say, look, here's the way you're going to monitor these things, and here's what you're going to look at, and here are some treatment algorithm guidelines that you can get through before you call for help. And then after you've called for help a bunch of times, you'll get good at these things. I want to talk for a moment about the barriers to this, because what you describe and what I describe is quite time consuming. And there's been a number of studies that have shown that if you screen for depression, but you don't give people extra resources to treat depression, they don't. So even if people screen positively, if the internist has to see so many patients per hour and they don't get extra time when they diagnose depression, they can't spend the time treating it. And the cost of not treating depression is much larger than the cost of paying for the extra 7 minutes it takes for somebody to actually think about what they're going to do to help this person. And so we need to create integrated models of care where when clinicians treat depression and do it successfully, they get rewarded for that in some way. Either they get more minutes for their visit or they get a bonus for their success. Because if you don't do that, people aren't treating depression. And that's why, as you said, we're better at picking up depression now than we are at getting people effectively treated. Part of that's measurement and part of that is resources. It's important to acknowledge those resources and the lack of those resources in patients like ours who are vulnerable populations, who are underserved and under-resourced, need more resources. So I just thought it would be important to say that one of the things about measurement makes care, although it makes, I think, patient care more efficient, it still requires a substantial investment of time to treat these patients. The guy I told you about today actually had developed some resistance to his HIV medicines. So the cost of the extra time to treat his depression before he saw me was more than offset in the increased cost of him changing to a more expensive medication choice. People worry about the side effect of medicine. They don't worry about the side effects of depression. People worry about the cost of medicine. They don't worry about the cost of not treating depression. And those are things that have to go into the equation. The lifetime suicide risk for somebody with major depression is someplace between 10 and 20%. The lifetime risk for death from an SSRI antidepressant is absolutely minuscule. It's not even 1%. It's a tiny fraction of a percent. So thinking about risk and benefit, you also have to think about the risk and benefit of not treating people. Right. I think that goes to supporting your view that we have to develop these integrated models and use measurement-based care in environments where people are getting up to speed on and getting good at treating depression. I think people who are experienced don't need it as much as people who are beginning.
And just to highlight a couple of things, at least in the way I was trying to describe it, because you've underscored how important this is. Part of how I was describing it is really talking about a task shifting piece. So, for example, no one's going to have the 40 plus years of experience that you have assessing and monitoring someone's response. That's not going to be something that most people are going to have, and that most people are going to be able to apply in an HIV clinic. But they can use some of these tools to get at some of that, to get at some important things to measure as people are deciding whether to increase a dose or consider switching something. So one is the key part of that task shifting piece. And the other is all this does not need to be done by the HIV clinician. There can be other support staff who can help a lot with this. So we'll use, again, nursing staff and social work to help with getting some of those follow-ups at maybe 4 weeks and 8 weeks before the person comes back for the 12-week follow-up. So you can get support staff to help. You don't need a psychiatrist on site to do this, although you do need access to having that as part of your virtual collaborative integrated network. So there are ways to try to find that balance between the tools you need to conduct the measurement-based care balanced with the resources that are available in a way that's going to help you carry this out better.
Absolutely. Well, are there any take-home messages that you want to make sure we cover that I've left out?
I don't think so. I think you've really hit the key points. It's important to make that diagnosis so that, for example, medication treatment that you're prescribing has clear evidence to support that it's better than not treating with that medication. We know that beginning treatment and following that response to the treatment gives us the greatest likelihood of making sure that person hits that recovery experience, that depression resolves. We know if we get them that far, that decreases their chance of having another depression and also decreases their chance of doing something impulsive that might harm themselves. So monitoring that response and looking at those measurement-based outcomes and really targeting that recovery is really critical points like you've mentioned. And then finding ways to create that virtual network. You don't have to have everyone there on site doing it, but you can virtually create a team who can help you administer this approach a lot more efficiently.
Well, I think that we should wrap up because our audience has many things they need to get done, especially going out and treating depression now. But I want to thank Clinical Care Options for the opportunity to present this information to you. And I want to tell Dr. Gaynes how much I appreciate him coming and joining us. He's done amazing work.
Well, a pleasure to always work with you, Glenn. The work that you do for folks and have been doing for 40 plus years is really remarkable. Thanks.
Thanks.
Thank you very much to Dr. Gaynes and Dr. Treisman for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the full program, Remind, Making Mental Health Care an Integral Part of HIV Care on the Clinical Care Options website, click on the links in the show notes for this episode. And to access all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast channel on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.